Hello, my name is Sean McNair. I'm a student physical therapist from Howard University, and today I'm going to be presenting to you my capstone project. It is titled A Conservative versus Surgical Treatment for Thoracic Outlet Syndrome, a Systematic Review. So, to begin, we're going to talk about thoracic outlet syndrome, and I'm going to give you a little bit of a background. Thoracic outlet syndrome, or TOS, is described as the compression of a neurovascular structures, the brachial plexus, as they exit through the thoracic outlet. Typically, TOS affects about 1% of the populations. These findings were put together by Physiopedia that stated about 3 to 80 people amongst a sample size of 1,000 people were found to have TOS. TOS is more prevalent in women than men due to 3 main causes: decreased muscular development, a greater tendency for rounded shoulders due to the presence of breast tissue, and a naturally narrowed thoracic outlet due to an anatomically lowered sternum. And typically, thoracic outlet syndrome affects individuals who are between 20 and 50 years old. Continuing on about thoracic outlet syndrome. Thoracic outlet syndrome is an umbrella term that takes into account a group of disorders caused by the compressions of nerves, arteries, or veins as they pass through a tight passageway between the clavicle and the first rib into the upper extremity. Multiple structures can be affected that pass through the thoracic outlet. You have the brachial plexus, the subclavian artery, and the subclavian vein. More on thoracic outlet syndrome. So this is one of the 3 types of thoracic outlet syndrome. This is neurogenic thoracic outlet syndrome, or you may see it as NTOS. This occurs when the brachial plexus is compressed or affected, and it's typically responsible for about 90% of all cases. So, venous thoracic outlet syndrome, or VTOS, is another form of thoracic outlet syndrome. This is when the subclavian vein is affected, and it affects about 3 to 5% of all cases. And finally, you have ATOS, or arterial thoracic outlet syndrome. This is when the subclavian artery is affected, typically 1 to 2% of all cases. Some of the signs and symptoms that are consistent with individuals who have thoracic outlet syndrome are pain, paresthesia, reports of weakness, increased fatigue, and decreased or absent sensation. All of these findings can radiate into the head, neck, face, and into the upper extremities. Here are some anatomical landmarks that are important when we're talking about thoracic outlet syndrome, specifically within the thoracic outlet. The thoracic outlet region is made up of 3 important areas: the interscalene triangle, the costoclavicular triangle, and the subcoracoid space. The interscalene triangle consists of the anterior scalene muscle anteriorly, the middle scalene posteriorly, and the first rib inferiorly. The costoclavicular triangle consists of the middle third of the clavicle posterior medial aspect of the first rib and posterior lateral border of the scapula. And the subcoracoid space consists of the coracoid process superiorly and the something anteriorly and ribs 2 through 4 posteriorly. Here's an image of the interscalene triangle. As I said before, it consists of the anterior scalene muscles, middle scalene, and the first rib. And then the costoclavicular triangle, we have a picture here in the bottom right-hand corner. It consists of the middle third clavicle, the first rib, and the posterior lateral scapula. And then we have the subcoracoid space, which is made up of the coracoid process, pec minor, and ribs 2 through 4. What was the purpose of this research study? It is a systematic review that examines the effect of conservative treatment plan to reduce the complications of thoracic outlet syndrome and compare that to surgical treatment. The significance of this study. This research study's objective is to provide clinicians with evidence-based information to offer the most effective and accurate treatment for individuals experiencing complications of thoracic outlet syndrome in the upper extremity. Here are some of my research questions and hypotheses. Is an isometric exercise program more effective in reducing numbness and tingling in treating an adult from 20 to 40 years old with thoracic outlet syndrome compared to no treatment? What is the most effective therapeutic exercise program in reducing pain out of manual therapy, isometric exercise, and active exercise for an individual with thoracic outlet syndrome? Is a PNF-focused treatment plan for an adult from 20 to 40 years old with thoracic outlet syndrome effective in lowering their DASH score? And is an isometric exercise program more effective in reducing numbness and tingling based on the DASH than only a surgical intervention on patients from 20 to 40 years old with thoracic outlet syndrome? Now to the methodology. To begin, we have to go over our search strategy. So the search strategy that I used was research databases such as PubMed, JOSPT, and Google Scholar, and this all occurred between March and June of 2024. Along with the research databases, scholarly articles were used such as textbooks and or credible websites ending in .gov or .org. No gray literature was used throughout this study. Only articles published between 2000 and 2024 were used in this study. They were all published in English and with full text availability. There was one outlier in the date. I used one article that was published in 1979, but it was due to the significant findings in the treatment plan that they used for thoracic outlet syndrome. So just a caveat there. And then many of the articles found were randomized controlled trials and systematic reviews. And then some of the key medical subject heading that was used was thoracic outlet syndrome, paresthesia, pain, numbness, and treatment types. The inclusion criteria consisted of subjects who were diagnosed with thoracic outlet syndrome. Their age was over the age of 18, and if they had tenderness around the clavicle or brachial plexus. Some of the exclusion criteria were studies who excluded participants who had received a prior nerve block procedure, prior steroid injection, presence of cervical instability, presence of malignancy, and hypersensitivity to their medication. This would be where my Prisma diagram goes. Okay, in order for me to gather good, reliable sources, I used two different types of quality assessments. I used the CEBM levels of evidence scale. This allows me to rate the level of the journals and the research articles that I was using. And then I used the Pedro scale, which is another way for me to go in and really assess how good of a journal article it was and how reliable it is. Okay, now for our outcome measures. There were 3 outcome measures that were used to figure out if the treatment types were being effective or not throughout this study. You have the DASH, or the Disability of the Arm, Shoulder, and Hand questionnaire, the cervical brachial pain syndrome questionnaire, and the visual analog scale. First, the DASH. The DASH is a 30-item questionnaire. It is used for the assessment of disability/symptoms, and it's important to use to understand the patient's overall functional status. Typically, the items in the DASH discuss the difficulty in performing different physical activities on the arm, shoulder, or hand, the severity of each of the symptoms of pain, and then activity related to the pain, tingling, weakness, stiffness, and the impact on social activities, work, sleep, and self-image that the pain or the issue has. Next is cervical brachial pain syndrome questionnaire. It's a 14-term questionnaire. Again,